EMS Academy training. Uh, we are honored tonight to have Nana Omole. She is a clinical assistant professor at Towson University. She has over 25 years in nursing with a profound commitment to patient-centered education at every stage of care. Her journey began in labor and delivery, where she quickly realized the power and impact of patient education. She became known for her compassion and skill, particularly in guiding even the most complex cases to successful non-surgical deliveries. Her passion for mentorship flourished as she served as a preceptor, instilling confidence and skills in new nurses. Since 2022, Nana has served as a clinical assistant professor at Towson University, where she nurtures a supportive learning environment, easing students' anxieties in clinical settings. I'll add to that, that's very difficult and quite an accomplishment. I work in a teaching hospital. Currently, she is pursuing her doctorate in nursing leadership at Salisbury University. Nana is dedicated to advancing nursing education and practice with aspirations to mentor and guide future educators and healthcare professionals. I welcome her tonight. I will let her introduce the meeting, her topic, which is OB related, and I think everyone should enjoy this. And it definitely has tremendous impact on what we do because babies like to show up whenever and wherever possible at the most inconvenient times. So thank you, and I turn it over to you.
Okay. Welcome. Hello, everybody. Thank you for having me. Hopefully, I can make this as interesting as possible. I was like, can this be face to face? But they're like, no, you all do it via Zoom. So I'm going to do my best and try to make it as interactive and as interesting as possible. And I'm not really sure exactly what everybody knows, but I will give you some information. And if you have any questions, please just raise your hand and chime in, because I want this to be pretty relaxed. We can ask questions. We can discuss things. I might know, I might not know. We'll figure out the answer as we go. Okay, so there's a couple different topics that we're going to be discussing today. And at the end, I'm going to show a little video, a little bit of my acting skills. I actually do simulation at Towson. So I did a little scenario and I incorporated my children. So I like to use free labor. So let me see if I can pull up the first one. And I'm not all that IT savvy, but I'm learning. Okay. Can you all see? Raise a hand or?
Yeah, we can see it, but you have menu
okay,
options
perfect.
blocking.
I'm sorry, something's blocking it?
Yeah, you know there are menu options for like what the share screen looks like.
Oh, okay. How do I minimize that? I'm not, is it blocking the whole thing or just the bottom?
I mean, it's just the bottom, so it fits fine. I don't know.
Okay. Childbirth emergency. So we're just going to talk about when someone actually is about to give birth. So sometimes, as the doctor just mentioned, sometimes babies, when they're ready to come out, they're just ready to come out. And as a nurse perspective, I know when someone's about to have a baby. How do I know that? I can smell it. I can see it. I can hear it. I can feel it. When I say smell, if someone has defecated on themselves, I know a baby's about to come, because that means the baby is actually in the vaginal canal and is pressing on the rectum. So if someone is telling you, oh, I feel like I need to poop. I need to poop. Or I feel like I need to push. That's a sign that, guess what? The baby might be on its way outside. Also, if I touch the belly, the abdomen, it's going to be hard. So when I say hard, it's going to be as hard as your forehead. So feel your forehead. You feel how hard that bone is? That's how it is going to feel. Like, and that's a firm uterus. That means that uterus is having an intense contraction. Also, when the person, by hearing, when a person is like grunting, so they're like, I feel, they're pushing. I know that because I can hear it. Okay. Also, if I look down there and I see blood, but it's not like blood where you cut yourself and you're bleeding. No, it's like a mucousy type of blood. That's called bloody show. And that bloody show will tell me, oh, you know what? Her cervix is opening up. It's getting close to that time. And the ultimate is when you actually see a head. So if you see a little bit of the head showing or a lot of the head showing, then of course, you know that a baby is coming. So what are some things when we get to a place, when we get to the house, sorry, when we get to their house, people are, screaming, the husband or the significant other is running around and like, oh, what are you going to do? Blah, blah, blah. There's some basic things that we need to know. So right away, you need to know how many weeks this person is because it makes a difference. Is she 20 weeks where the baby's not going to be viable? Or is she 38 weeks? That makes a big difference. So you need to know the weeks. Out of everything, that's the first thing you need to ask. Okay. And then also, how long have you been contracting? How far apart? Maybe she's in pain. So you have to involve who else is in that room. So if it's one of the kids or the husband or mom, whomever, ask them, how long has she been contracting? How far apart are they? How many babies does she have? How many pregnancies does she have? Ask those type of questions. Also, did your water break?
A lot of people are going to have a hard time. Oh, well.
I'm sorry. Okay. And if I'm talking too fast or you have any questions, please just chime in. Please chime in. Also, if the water breaks, you want to know. Hold on for a minute. Is there any way I can show a little piece of like a window of myself on here? Because I want to show something.
We can see you.
You can?
Yes.
Oh,
But
I
you
can't
can
see
also change your view at the top right. It should say view. And once you select it, you can change it to side-by-side speaker.
Oh, okay. I don't see it. Side-by-side speaker.
It should
I don't
be,
see it.
it should say view at the top right next to where you would like minimize your screen.
There's nothing here. I don't see anything. Because I guess it's on presenter view, so there's nothing.
Oh, yeah, that may be it. But we can still see you.
You can't. Okay. Well, then okay. Okay. Huh?
Right now you are side by side.
Okay. Okay. Well, then I'll just pretend that I can see myself. Okay. So where was I? Okay. So if someone's water breaks, a lot of times, so see this baby doll? The baby's in here. And when someone is having contractions, is about to deliver, sometimes guess what's holding the baby up from having to come out of that vagina? Literally, this is holding the baby up. So if you come in and initially the person is having contractions, you see a little bit of, even if you see a little bit of the head, but she has not ruptured, sometimes the bag of water is holding that baby up. But what happens if she says, I broke my water? Then guess what? You better hurry up and make sure you have your gloves on. Make sure you have your gloves on because that's the only thing holding the baby back. You see how easy the baby just came out? So you have to ask that. Also, you want to make sure it's clear. If it's greenish, it's telling me that the baby has pretty much pooped in the pool, meconium stained. So we don't want the baby to aspirate that fluid. So it's very important to make note of that because the hospital will want to know. before you get there. Okay, that she actually baby is meconium stained. Also, we already talked about the pain and sensation. If the baby is down in the canal, they're going to have a lot of rectal pressure, a lot, and they will tell you. Now, if someone is also delivering, please keep in mind where this is occurring. Sometimes it feels better for the mom to actually stand like this, like she's standing up like this. Guess what? If she's standing like this and it looks like she's going to have a baby, please get between her legs and have your hand down there, because it wouldn't be good if this baby literally boop, falls. That wouldn't be good. What do you think might happen to the baby? Anybody? No talkers? If the baby falls out of her vagina and onto the floor? Nobody?
We have some comments in the chat saying head injury, heart landing, brain damage.
Yeah, we can get all of that. Hematoma, because guess what? Babies are not born with clotting factors. So a lot of times they won't clot. So something that should be just a little goosebump will end up being a huge hematoma. And we don't want that. Okay. Like you said, it can even cause brain damage. We don't want that. So please make sure, be cognizant of where she's delivering, how she's delivering, and just be ready with your gloves to catch, just in case. Just in case. Also, you want to know medical history if you can get it, because hypothetically speaking, let's say they say, oh, you know what, she was supposed to have a C-section. That's some information that you would definitely need to know. Or they already told her, you know what, the baby is breech. The baby's coming out breech. That's something you might want to know. Something like this. Because now we don't deliver, doctors are not really trained to deliver breech babies. So those are some things you want to know. Also, you might want to know if, let's say you just went and found someone in a crack house. Okay, is she on heroin or cocaine or whatever? You might want to know that, because guess what? If the baby comes out, we want to know what we're dealing with the baby. Is the baby going to go through withdrawal? So it's good information to let the hospital know that, oh, we just got her off the street and she might be on drugs. It's good for you to know. Any questions on this? I can't, let me see this. Let's see the chat. Okay, I can see the chat. All right.
No questions in the chat.
Okay. Now, okay. So when the baby's coming out, so we want the baby to be definitely coming out vertex, head first. Sometimes they might come out buttocks first, but hopefully it's pretty much head first. Now, when it's precipitous, precipitous means pretty much the baby is coming out within a 3-hour period. So from the time the person started contracting to the time the baby comes out in a 3-hour period. Pushing is called the second stage of labor. We have first stage, second stage, third stage, and fourth. First stage is when they're actually in labor up until 10 centimeters. Centimeters. And then second stage is 10 centimeters to pushing. So let's say you get there when she's pushing and this baby is crowning. So crowning, you're going to see the head, but it's like you'll see a circle. So the perineum and the labia is covering that head, and you'll see the head, and it stays there. What you have to do to help support the perineum. So the bottom area, you simply support it. So the baby just doesn't fly out. Because if the baby just pretty much flies out, you have risk of like a really bad laceration. And that's what we're trying to avoid. So if you know the baby's coming out, simply get your glove and then support the perineum. And the baby will come out by itself, just like that. It will just come out like that. Okay. Now, baby's head comes out and you see a cord around the head. Simply pull it over like you're just taking off your necklace. Let's pull it over the head like that. And the baby will come out just like that. Okay, just like that. Now, hypothetically speaking, let's say it's around his neck and it's too tight. I'm not really sure. Do you all have clamps on the ambulance? I don't know.
There's a clamp in the OB kit.
Oh, okay, okay. So you get a clamp, you clamp two sides of it, and then you cut in between. So you clamp two sides and cut in between so the baby can go through if it's too tight. All right, that's how we do it. Now, so if the baby comes out, what are we going to do with this baby? Pretend my baby comes out. The main thing we need to do, we call it warm, dry, stimulate. Warm, dry, stimulate. So when a baby comes out, we are warming the baby, literally, we're wiping the baby. That wiping is stimulating. And we're drying the baby, okay? And what you do is vigorously, like, rub the back. If the baby's not crying, just vigorously rub the back and the feet, okay? And wipe this baby off. And the baby should cry. And you just do this right on her chest, okay? Clean this baby up. This is wet. So babies lose a lot of heat simply from evaporation, from the wetness. What are we going to do? All we have to do is, once we're done with this, and let's say you're in the ambulance, put this baby on her skin, right, like this, and then put a blanket over top of her and the baby. Okay, so let's pretend this is the blanket, a new one. I'm just going to put it over top. The cord, you don't have to rush to cut it. You don't have to rush to cut it. Now we do delayed cord clamping. So we don't have to rush to do that. And delayed cord clamping, we could do it up to like 3 minutes. If the baby is fine, the baby is vigorous, there's no need to cut it right away or clamp it. So what we do is we'll leave it on and let the last bit of red blood cells and iron go into the baby. You know, it helps with jaundice, anemia, and things like that. And when we clamp it, be sure when you clamp it, don't clamp it too close to the navel. Give it a couple inches. Clamp it like this far. You know, a couple inches. Why am I saying that? Because when you clamp it, hypothetically speaking, let's say you get to the hospital and the baby has respiratory distress and there's some issues going on and they have to put an IV in the baby. Instead of sticking this baby trying to find an IV in his hand or his head, they can go right into the umbilicus. It has 3 vessels. These are the arteries, the 2 arteries, and this is the vein. And they can go right into that and then supply medications to the baby, fluid. But if it's too close, they can't cut underneath it, if that makes sense. They can't cut. But if it's up here, they can cut underneath it and then put the IV in there or the fluids in there. So make sure you don't cut it too close to the navel. All right. Suctioning. If the baby is screaming and crying, there's no need to suction. You don't have to suction. But if the baby is kind of like gargling, and you actually see like mucus in the mouth or fluid, you get, I'm pretty sure in your OB kit, you have a bulb syringe. Get the bulb syringe, you squeeze it first, and then you just suction it out. Okay, just suction it out. And the baby should be good. Okay, so this is a healthy baby. APGARs. We have this thing called APGAR, and it just gives us an assessment of how the baby's doing. If you can do it, it's great. APGARs, it goes up to 10, scoring 0, 1, and 2. We have A for activity. So if the baby's like, okay, that's going to be a 2. If the baby's heart rate is above 100, that's going to be a 2. Grimace is baby screaming, crying, sneezing, 2. Appearance, babies will always, as I've been doing this over 25 years, I've never seen a newborn baby with totally pink feet and totally pink hands. They always have acrocyanosis. So a hint, if a baby comes out vigorous and crying, that's 9 and 9. We don't give babies 10 because they're always going to take off 1 for hands and feet. Okay, and then we have respiratory. Is the baby crying? Is the baby, like intermittently crying? Baby not crying very low? That'll be like a 1. So that's APGAR. Now, when a baby is born, what are we going to do? When she's in the ambulance, get a set of vital signs. I think everybody's house is probably a good 15 to 20 minutes away from the hospital. So you'll fairly get there quickly. So it's important, make sure once that baby comes out of the vagina, please yell out to your partner, the baby was born at 2200. 2200. Once you finish wiping the baby down and all that good stuff, get a set of vital signs on a mom and cycle it. So cycle it every 15 minutes. Cycle blood pressure, pulse ox, and you can get 1 temperature on the mom and respirations. So cycle it. That way you have at least you have a baseline until you get to the hospital. Also, the baby, if the baby's vigorous and doing well, and it takes, let's say, 30 minutes to get to the get to the hospital, after you're done, after the 1 minute and 5 minute APGAR, after you're done doing that, if you can get like a temperature, maybe 15 minutes in, get it. But if you can't, just make sure the baby is breathing, and then also the baby has a pulse rate. If the baby's pulse rate is not over 100, then you're going to notice signs like you'll probably notice some cyanosis. Baby might be lethargic. The color doesn't look good in the baby. You'll notice those type of things. All right. So you don't, if you can, get a set of vital signs. And we do, I'm pretty sure you all notice, temperature, axillary for the baby. Okay. So primary vital signs, consciousness, and life threats. Also, you're going to get the APGAR and birth time. Also, let when you're giving a report, let the nurse know the timeline. Okay, we got to the hospital. We got to 6081 Joseph Scott Lane, and we entered. The mom was having a baby in the bathtub. So she was in the bathtub. Mom had a baby at 2200. We placed the baby on her chest. The baby was fine. Baby was vigorous. 99 APGARs. Placenta is still in her. Like, just give them a timeline. You clamp the cord. When you cut the cord, if you do cut the cord, just a good timeline. If she lost a lot of blood, if she didn't lose that much blood, let them know. Also, if anything, like, I guess, negative happens, what did you do? So hypothetically speaking, let's say you notice that mom was bleeding excessively. You did fundal massage. Okay, I did fundal massage on her. That's an intervention. Or if you notice baby stopped crying, you stimulated the baby. So it's good to give them, what did you do if something negative happened? Additional information, like I said, the environment, how much blood did they lose, if the placenta is still inside or not, and then also who's coming with her. Was she by herself? Does she have 10 people coming from the house to the hospital, at least everybody knows who's coming. So those are some things that you can tell the oncoming nurse. Okay. I hope I didn't bombard you all too much. Was it too boring? Yes or no?
No.
You got some no, nope, nope, nope.
They wouldn't tell me later on. They would be like, yeah, that was boring.
You're
So
with a bunch of EMS people. They have no trouble telling you what they think.
so I'm gonna have another video to show you all. I mean, another PowerPoint to show you all. Do you all have any questions? Anything? And I'm sorry if I'm giving it in the perspective of a nurse, but I'm trying to. I had actually one of my son's friend is an EMT, and he came over to tell me different things that he does on the ambulance and things like that. So he told me things that you all see and don't see, and things that I should discuss and not discuss. So things like that. So I'm trying to curtail it to you all. And you all are the first responders. So I know some things that when you all come, I'm like, God, they could have done this or they could have done that. And I just want to just let you all know how we're totally indebted to you all, honestly. So, this is a team effort and we try. Does the passing of the placenta matter in terms of performing? Oh, that's a good question. That is a good question. So someone asked about the placenta. If the placenta has not, say, let's pretend like the placenta has not, remember I told you you don't have to deliver the placenta, it could just stay in. If it has not delivered, do you massage the fundus? You don't have to, because what happens is when the placenta is ready to be delivered, there's even a gush of blood that comes with it. And a lot of times it can be delivered by itself. Like you don't have to pull on anything. Can be delivered by itself. Now, if it is delivered, then yes, you should do the fundal massage. Yes. But if it's not delivered, don't worry about it, because it's going to be gushing blood until it comes out. Let me get the next one.
The next
And you
question
said,
is, can you review some more complications?
I have shoulder dystocia, and another is like, you mean like shoulder dystocia and things like that? Because I have that in another PowerPoint.
Terry, feel free to jump on if you have any specific complications you want to discuss.
Prolapse cord, I have that also. I'm going to talk about that.
Awesome.
Can you also? Okay, so gravida means how many times you've been pregnant. You could have just urinated on a stick and then it said positive, and then guess what? 5 weeks later you miscarried. Guess what? That counts as your gravida. So anytime you have been pregnant, that's gravida. Parity means any child that you've had over 20 weeks. So if it's before then, it doesn't count. So parity is any child you've had over 20 weeks, period. Now, when it comes to contractions, what happens is that it starts out like phase 1 from 1 to 3 centimeters is mild. So mild is your nose. So feel your nose, nice and soft, right? So it's uncomfortable. So those contractions are irregular. They can be like 8 minutes apart, 10 minutes apart. They're all over the place. Those contractions don't really hurt as bad. Some people, it hurts them. When I was 2 centimeters for my first baby, I was like, I'm dying. I get to the hospital like, ma'am, you're only 2 centimeters. They laughed at me. I know they laughed at me. But, pain is relative, right? That's what they say. Pain is relative. So it's not going to be as intense. Then it gets to you get to 5 to 7, 8, 5 to 7, 8. It's getting more intense. That's when you're like, I need an epidural. Now it's like every 5 minutes. They're getting closer. Then you get to the point where you're like 7 and above. Now your body is really trying. So moderate is that 5 to 7. Moderate is this. You see it's soft on the top, but hard in the bottom. And then firm at the end, when you're ready to deliver, it's going to feel like your forehead. So those contractions are going to be like 2 to 3, 1 to 2 minutes apart. And your body is ready to push that baby out. And the more babies you have, the faster that baby flies out the vagina. Boom. That's what's going to happen. So if someone comes in and says, "Oh, this is my 5th baby," just get your gloves. You're gonna be catching the baby. She can just laugh,
There's a question
and the baby will come
There's
out.
a question that says, when you're 30, there's a question in the chat we should address. It says, when you're 30 minutes out from the hospitals, I'm assuming, when do you transport or when do you stay and deliver? And the advice I would give on that, because it's very unpredictable, unless she's crowning. Once the baby's crowning, pull over. But otherwise, you want to try and get to the hospital. So if you're 30 minutes out, what do? If they're crowning, which means, as we described earlier, there's a little bit of the head showing through the birth canal.
Like that.
Where you're going to deliver. You're not going to make 30 minutes. But if you're not crowning, try and go to the hospital. But as everyone knows, many times medic units have pulled over on the side of the road and finished the job because you didn't quite make it. And I can also tell you many times they pull up in front of the hospital and deliver right there. But you took the shot. But yeah, if they're not crowning, transport.
Yes. I've had it where, because once they get into the ED, they're calling us and they're like, "Oh, someone's delivering." They call it an alpha at Howard. So we run that down. I've had it where she was crowning and I literally push the head in until we got upstairs and then let go and the baby, pew, shut up. Yeah.
That would be precipitous.
Yeah. So, any other questions? No? Okay, let me find. Okay, now you said, how do I just do view and then side by side? Let's see.
Yep, this should be options, and one of them is speaker or gallery, multi-speaker, depending on what it is you'd like to see, but we can see you next to your presentation when you present the screen.
Okay. So would I put multi-screen so I can see my screen and then see my PowerPoint and then see myself?
You can do speaker view.
Okay, it's on. Okay, it's on. Okay, let's see what happens here. All right.
Also, I'm not sure if we got this question already. It says, do you have to worry about keeping the baby above or below mother's heart for backflow?
I don't understand. Oh, what do you mean for when the baby comes out, like when the placenta is still attached, or I'm confused?
Paul, do you mind elaborating on your question?
The question is, do you have to worry about keeping the baby above or below the mother's heart? When you think back, I'm guessing you're thinking to the placenta. The placenta is sort of a one-way valve in that regard at this point, because once the baby's out, the placenta is going to go through several changes where it's going to basically contract and separate from the uterine wall to be expelled. So generally, generally the hospital will wait 1 minute to 3 minutes, and then they clamp the cord. But it's usually not far after that the placenta is going to arrive because it's already separated from the uterine wall.
That answers the question. Thank you.
Okay, thanks. I'm sorry, I didn't understand it at first. I wasn't really sure. Okay, thanks. Okay, let me see if I can get this up. I'm sorry, I'm really hot. Okay.
While you're doing that, there's another question. It says, any comment or suggestions on handling mothers on blood thinners?
No, I just make sure that the hospital knows that she's on blood thinners.
Generally,
Yeah,
the
because-
blood thinners used in OB patients were prescribed by the obstetrician for a
Mhm.
reason, and the delivery was already taken into consideration. Hopefully you take it to the hospital where they're registered at and they'll handle all of it. But the uterus is going to, after the baby is born, the uterus is going to contract down most of the time. If not, there's medicine they'll give at the hospital. But you want to, once the baby's out, you want to arrive at the hospital as soon as possible so this becomes a non-issue for the EMS unit. And amazingly, they will not make you wait.
Yeah. Okay. Can you all see this? Yes?
Yes, we can see the slide
Okay.
that says OB emergencies.
Yes. Okay. So OB emergencies, life-threatening complications can occur during pregnancy and childbirth. Quick recognition and response are essential in saving lives. Precipitous birth, hemorrhage, abruptions, preeclampsia, ectopic require immediate intervention. Okay, objectives, we're going to recognize the signs, understand interventions, assess outcomes, and apply protocols. Okay, so what we're going to deal with today is postpartum hemorrhage. We all know about postpartum hemorrhage is when someone just bleeds out. Now, in my field, this is one of the leading causes of mortality worldwide. Now, there's a lot of different risk factors, but most times it's just really unpredictable. I had a woman, third baby came out fine. Her other two were fine, no problems with them. Within about 30 minutes, she started bleeding and it would not stop. And someone who was, I would say, like a tan color was as white as paper by the time we got back to the OR, because she was literally bleeding out and she had no risk factors. So sometimes it's just unpredictable. What is the main cause of postpartum hemorrhage? Uterine atony. What is uterine atony? The uterus is soft after birth. It's not supposed to be soft. It's supposed to be hard, just like your fist, very hard. Because what happens is, the way things work is, once that placenta comes out, the body naturally tries to heal itself and heal that uterus. So it's trying to go back to normal. The normal size of uterus is about like your fist. So it's trying to contract. And how does it contract? The body lets out oxytocin. But now we have something called Pitocin. So anybody here who's had a baby or seen a delivery, every hospital gives Pitocin afterwards. It's preventative, so the uterus will contract. But sometimes the body's like, I'm not doing that. The uterus is like, I don't want to do that. I'm tired. You have overextended me. That's one reason. And now I'm not trying to go all the way back to normal, because you have it's kind of like a balloon. When you blow a balloon to its maximum and then let all the air out, it doesn't go back to normal. Versus if you just blow it a little bit, it'll go back. So if it's overextended, it takes time for it to go back. And sometimes it's not, the oxytocin or Pitocin is not working. Also, if you have multiples, or if you have, or if you've been in labor for a long time, where you've been contracting for maybe 48 hours, the body is tired. The body's like, I've got this baby out, I've contracted. Now you want me to do more work and continuously contract, so the uterus will try to go down? No, it won't work. So there's a lot of different reasons. That's 70% of the time. And these bleeds happen usually the first 24 hours. That's when it happens, it's first 24 hours. So, and in your instance, if you find someone at home, sometimes people have home births. I was just in the hospital the other day and someone had a home birth and she was having complications. So people have home births. So if someone had a home birth within 24 hours, she's really susceptible to uterine atony, because that's the time they bleed the most. Then after that, you have secondary. So primary is first 24 hours. Secondary is from 24 hours until 12 weeks, you can bleed. What is postpartum hemorrhage? The amount 1,000. It used to be 500 for vaginal and 1,000 for cesarean, but now it's 1,000. 1,000 for everybody. So you have a baby, 1,000 mLs you have to lose. Now, it's very important to know how this person is bleeding. Is it tone that I just discussed? Is it tissue? Tissue means this placenta, a piece of it is still left in the uterus. The body doesn't know that that piece is not connected to a baby. The body only knows is that there's a placenta here, and my one job is to give blood to that baby, give nutrients to that baby, give oxygen to that baby. So instead of it going to the placenta, it's going into the uterus and coming out. So that person bleeds. So that's retained fragment or membranes. Thrombin, that's a blood disorder. So a lot of times people already know that they have a blood disorder. So with those people, we already know we're going to put blood on the side for them. We'll type across them and they already have blood waiting for them, just in case. Trauma. Let's say those precipitous births. The baby comes out. You are supposed to be 10 centimeters when your baby comes out. But sometimes you might be 8 centimeters. And that baby still just comes out. What happens? You get a laceration on your cervix. So it's not your uterus. Your uterus is going to be nice and firm, but you're bleeding from your cervix or you're bleeding from your vagina. The baby scratches the vaginal walls while it comes out, or the perineum is torn. Remember that laceration I was talking about? Is torn, or you have a hematoma or a uterine rupture, like literally your uterus is ruptured. So those are all trauma that may occur. Okay. Let me just go over the interventions now. I'll go over it now. So with tone, if let's say you get to someone's house and they had a home birth, 12 hours later, there's a lot of blood. She's saturating a pad every hour. So when someone's saturating a pad every hour, that's very heavy, and that's when we need to start measuring how much that person has lost. But of course, you're not gonna have a scale, but it's good to, if you go to someone's house and they have a lot of blood, it's good to be like, hey, can you put it in a trash bag? So that way, when you get to the hospital, we can weigh it and say, oh, you know what? She has lost 1,500. Oh, she has lost 700. It will help. So you notice that she's at home, there's a lot of bleeding going on. You feel her fundus. And when I say you feel a fundus, you're literally kind of just doing like this. It's like this. And after birth, the fundus should be at the umbilicus. I don't know if you can see can you see me up here? Okay. My umbilicus. Can you see that?
No.
Someone say yes. You can? Yes. Okay. So you're going to be massaging there. So it should be there. That's where it should be. Now, if it's to the left or the right, that means that person has a full bladder, and that can cause uterine atony. And it's going to be soft. It'll be soft, and it'll be like maybe +2. So it's going to be above the umbilicus, to the right or left. So anytime you feel a uterus and it's to the right or left and it's soft, then just know that that person has to urinate. They have to urinate. If they can't urinate and it's like maybe maybe sometimes the bladder, the urethra, due to trauma, they can't urinate and they retain urine, then you will have to cath them like a straight cath and see if that will help. Also, I noticed in your protocols that you all don't have Pitocin, I guess. I don't think you all have Pitocin, but if you already know that it's a tone thing, just make sure when she gets in the ambulance, someone continues to massage her uterus, get her vital signs, because she might become hypovolemic. So cycle them literally every 5 minutes. Okay. Also, some things that you might do, please put in an 18 gauge, nothing less than an 18 gauge. Because what happens, and this helps us a lot, because what happens is someone like that might end up with a hysterectomy. So once they become hypovolemic, it's very difficult to find a vein. So if you're getting there, your first responders, you're getting there and she has veins, put two in, one here and one here. Because guess what? This one will be for blood and this one will be for the Pitocin.
Yeah.
And we don't have to worry about
Ambulances don't carry Pitocin or Cytotec or Hemabate or Metrogen.
I'm sorry?
The ambulances don't carry Pitocin, Hemabate, Cytotec, or Metrogen.
Yes, and
that-
yes,
that's
I noticed
provided.
that. I noticed that. So since that, you all don't have, they're gonna automatically give those medications once you get to the hospital. They're gonna automatically give the ones that he mentioned, Cytotec, Metrogen, Hemabate. You all have TXA, though. I saw that. Right? Am I correct?
That's correct. They do carry TXA.
Yeah.
The thing to do though is we would not delay transport at that point. It would be to hurry up and get them in as fast as
Yes.
possible to the hospital.
Yes. Yes. So, and TXA really works very well for uterine atony. It works very well with one of the uterotonics, like he mentioned, the Cytotec, Pitocin. So they need that to work hand in hand because the TXA is not going to work by itself because uterine atony is what the problem is. And we need the uterus to contract. So putting 2 IVs in would be the best thing you could do. Massage your uterus. Also, keep the blood, put it in a trash bag, and give it to the nurses. So that way, or the staff, whoever is there, that way they can weigh it. That's one thing that you can do to help. Tissue. Now, if you're massaging the uterus and it's nice and firm, most times, I'm sorry, not tissue, I meant to say trauma. Most times with trauma, the uterus is going to be firm, but she's still bleeding. So with that, it's good to ask questions. Hey, when, how did your delivery go? And, did you have a laceration? Ask if they had laceration. Did they mention anything about laceration? Then it might clue you in that, oh, you know what, maybe she's bleeding from that area. All right. So again, with that, if it's excessive and it seems like she's saturating pads, 18 gauge, definitely 18 gauge. Tissue, with that, you can't do anything as well, but you can't put in the 18 gauge as well. With that one, you can't like massage or anything because the uterus is not going to work. What we need is for that fragment or the placenta to be taken out manually. Only the doctor can do that. So they have to be taken to the hospital. Okay. Things that you want to know. You want to know gravida parity, not just when did she deliver? Did she have a vaginal? Did she have a cesarean? Did she have a vaginal assisted delivery? Vaginal assisted delivery means like she had a vacuum delivery or she had forceps. Those deliveries, a lot of times, they have lacerations on the walls of the vaginal canal. Did she have any complications? Did they say anything about, we had to go in manually to take out the placenta? Sometimes they leave a little piece in there. What complications did she have? Medical history, you want to know about. Did she have any clotting issues? Also, did she have any fibroids? What medications she's taking? Kind of like when you were asking about the blood thinners. Did she take any blood thinners? It's good to know allergies. Signs and symptoms. If she's saturating pads, or she's trickling, or there's a lot of clots. And when I say clots, not those little clots like the size of a penny, but clots like maybe the size of a peach coming out. That's a problem. Also, we want to see if she's going into hypovolemic shock. How do we know that? We're taking her vital signs every 5 minutes. Also, you will see it. Is she becoming pale? Someone who had plenty of color in her, now she's becoming very pale. She looks white. Is she in and out of consciousness? Does she no capillary refill? What does her blood pressure look like? Is her blood pressure going down? And it's good to know, because if you got her and she was at 100 over 65, now by the time you get to the hospital 30 minutes later, she's 70 over 40. We know that there's a problem. She's going into shock. Also, is she tachycardic? Is her pulse ox like 92? Because now she doesn't have red blood cells going through. You know, the volume has decreased. Also, when she's in that in the ambulance, make sure that she's actually laying flat. Okay, don't have her sitting up, because the gravity is going to pull the blood down, and we want the blood to kind of stay in the torso area where the major organs are. Okay, so have her laying down. Those are some things that you might want to do. Let's see here. The environment. Where was the delivery? Because like I said, it was a home birth. That means she never went to the hospital. So you have to know, and then also what time did she deliver? That, like I told you, that first 24 hours is imperative. And most of them are going to be uterine adding during that time. After that time, it just might be like trauma, or it might be tissue after that. So these are some things that we talked about. You do bimanual uterine massage. You don't have Pitocin, so you wouldn't give that, but give fluid for sure. Give fluid. The person is going to need that, because they might go into hypovolemic shock, and LR would help, with the volume. These are the medications that doctor, what's your name? Dr. what? I forgot the last name.
Sagal.
Dr. Sagal. So these are the medications that he was talking about. Methogen. This is carboprose, but that's hemabate. And misoprostol or Cytotec. Yes, those are the ones that we use, and TXA. That's something that we use. And this is
first.
Huh?
We always start with Pitocin first.
Yes, that's the first one. Yeah, first line. Now,
and it works most of the.
And we give it out like water. That's what we give. We just load them up with oxytocin.
Last 20 units into the IV bag and open it wide.
Yes. Also, I meant to say, let's say you get to the house and it's just really just heavy bleeding. You know what helps naturally? If she's breastfeeding, put the baby on the breast. Put that baby on the breast, because that's extra oxytocin going through her system. Okay, naturally, when the baby's on the breast. Now, of course, if you could tell that this is a massive bleed, don't worry about that. We don't care about that. Baby, she has to go. She has to leave. But if it's just just a heavy bleed, baby will do wonders with that. So actually, it's good to even put the baby to breastfeed after a delivery. So if they're in, let's say it's taking 30 minutes, baby is already delivered, and she wants to breastfeed, let her, because that's giving her oxytocin. Okay, EMS considerations, blood loss collection. Remember, put it in a trash bag. Vital signs, do it every 5 minutes. Do regular massaging. Remember the IVs, and give fluid, the LR. Also, communicate. Let the hospital know what's going on, because a lot of times, like in the hospital, we'll get someone's coming in with a bleed. We don't know what the amount is, so we don't know what we're prepping for. We don't know if we're prepping for a massive bleed, or we're prepping for someone who is just bleeding a little bit too much for their comfort measure. I mean, for their comfort. We don't know that. So if you state, hey, she has saturated 10 chucks, we know that this is a massive bleed. Her vital signs, she started at 120 over 80, but now it's trending down. Now it's 60 over 30, something ridiculous. But now we know what we're dealing with. We're dealing with someone who's bleeding and is in hypovolemic shock. So to keep constant communication is good. Also, the person might feel like they're dying and they might say it. So don't forget the support people, the support person. Do you all let support people in the ambulance? I don't know. I was wondering. Yes, no?
Generally, the back of the ambulance is restricted to the patient and the paramedic.
Okay.
A family member can ride up front on the way to the
Oh,
hospital.
but they're not in the back. Okay. 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 So you're going to be the one with that mother. So it's good to talk to her and reassure her we're doing everything we can. Don't say, if she says I'm gonna, I feel like I'm dying, don't say no, you're not gonna die. We don't know. We don't know. Because postpartum hemorrhage is like a code blue in the ED. It's literally life and death. Okay, so you do not tell them no, because we don't know. We just don't know. So we always just reassure them we're doing everything we can. We're going to get to the hospital. So you're only 10 minutes away. We're 10 minutes away. We're almost there. They're going to take care of you. We're taking care of you. We're doing everything we can. Just reassure them. Okay, reassurance is everything. If you have to hold their hand, hold their hands. If they want to, if you're Christian, she's Christian, and you want to pray, pray. Whatever, whatever to ease their anxiety, whatever it is that you can do to ease their anxiety, do it.
The other thing the ambulance should do if they're dealing with a postpartum hemorrhage for whatever cause, is they can radio ahead to the hospital to let the hospital know, because they'll basically address it on arrival, and they can even have blood ready, or they'll treat it as a trauma and maybe do the initial resuscitation in the trauma bay and just give whole blood to get it started,
Okay.
because it's very serious, as you said, postpartum hemorrhage. So, but the ambulances have the ability to communicate with the hospital, and they will, if given advance notice, have the OB team meet the patient
Mm-hmm.
in the trauma bay at the hospital, and they can transfuse, they can do whatever. Sometimes it might just be as simple as removing an entrapped placenta.
Yes. There's a situation that happened, and the person was hypoxic, she was pregnant, I think. I'm not really sure. I don't know how many weeks. I forgot how many weeks, but it was over 25 weeks. Anyways, by the time she got in, she was dead. So that's when so they actually cut her and did the cesarean in the ED. And they said when they opened her up, the baby came out, blood poured all over the place. They said people had to go and take a shower. It was that much blood that just poured
There's a
all over the
question
place.
in the chat about how often do you have a clot break loose to lungs or elsewhere? And I think more specifically for OB patients, just to add, it's not just the blood clots you're worried about. It's more often the amniotic fluid or an amniotic fluid embolism. That seems to be more of a bigger issue as opposed to a blood clot. Just as an aside, again, it's based off of the anatomy and physiology of the uterus during labor.
Yes. And that one, I think the mortality is like 70%? It's high. It's really high so I actually have never experienced that, and I don't want to, because a lot of people pass away with that.
Amniotic fluid embolisms can be a lethal event.
Yes, it's very lethal. Like I have to
It's
look
a
it
real
up, but
cause of
it's the mortality is very high. And it's really
Yeah.
nothing like, yeah, there's really nothing like intervention wise that you can do. You just have to get her to the hospital. You give her
The incidence
IV.
of
You have to
survival
give her
of amniotic
fluid.
embolisms is low. It's very low for
Yeah,
survival.
yeah, it's unfortunate. Okay, so things that we, to do to stay abreast of this, simulation trainings, protocol review, and team debriefing about what occurred, and then give good communication, as in tell the staff at the hospital exactly what has happened, where did you find this patient, how much blood did you see, and like I said, vital signs, things like that. You're going to keep them abreast of all these things. Okay. Any questions on Any questions? No, okay. So help is not a good situation. How do you know? So I'm going to talk about I have a slide of preeclampsia. I don't go into HELP syndrome.
HELP is basically
Hemolytic.
hemolysis, elevated liver enzymes, and low platelets. The basic treatment for HELP is to deliver the baby.
Yeah. Yeah. And then, so that once they get to the hospital, they deliver the baby. And sometimes it happens afterwards, after
Yes,
you deliver. Yes. And they have to be on MAG right away, because we don't want it to go into DIC, because the platelets will go down severely low, and then they could bleed out.
The mentioned before was about, don't forget the oxygen. Absolutely. Every pregnant woman who shows up in your ambulance, put them on a nasal cannula. They're not going to tolerate the mask as much, but give them a nasal cannula.
Well, actually, if they're pregnant, don't give them nasal cannula. Give them the non-rebreather, because it doesn't get to the baby.
Well, everything raises the FiO2.
Huh? What did you say?
Everything will raise the FiO2. It's just a matter of how high. The baby will, with the fetal hemoglobin, will steal it from the mother before the mother gets it.
Yeah. So like I don't know. Like I know I'm just going based on the hospital. Like in the hospital, we just don't do when they're pregnant. We just put the face mask and then put it up to 10, at least 10, so it can get to baby if need be. But you know what they're getting? You know what they're getting away from that now for some reason. They're getting away from oxygen for like D cells and stuff like that. But that's another story. You don't have to worry about that. Don't worry about that. Okay. Go to the next one. Okay. The time is winding down because I have 30 minutes, right? Okay.
You have an hour if you'd like.
Oh, I have an hour? Oh, good. Okay. Okay, good. Perfect. I didn't know that. Okay, perfect. Okay, here it is. Please move the window away. Can you see this? Preeclamptic patients?
It seems to be loading.
It's loading? Oh, okay. It's weird.
There's a little circle there.
Let me take it off again. Let me try it again. Can you see it now?
Yes.
Yes, okay. Okay, we're talking about preeclamptic patients. Okay, let's go. We're going to talk about criteria, assessment, and intervention. Okay. Now, I looked through your protocol to see, what you all can give and things of that nature. So criteria over 20 weeks and up to like 6 weeks postpartum, people can be preeclamptic. Now, what's preeclampsia? Preeclampsia is actually when the blood pressure is like 140/90 with proteinuria. You won't know that. You're not going to know that. But you will know if you take a blood pressure is over 140/90. Also, sometimes it comes with symptoms. And I'll go over these symptoms. Moderate is 140 to 159, over 90, over 109. And severe features is 160 over 110. Now, the symptoms that you might face or see, so when you go in, she might be like, oh, I have a horrible headache, okay? Or she might be seeing spots, or, altered mental status. Usually it's not that bad. Or they have epigastric pain. That's where your liver is, up here. You might experience a little bit of nausea, vomiting. You have edema, so you notice their hands are really swollen, or their feet are very, very swollen. Sometimes they might have shortness of breath. That means they might have like edema. They might have edema in their lungs. Chest pain. Those are some things that they might experience. So if you see someone, like if I saw a patient, I remember seeing a patient, she comes in and she looked like she had elephantitis. That's how big her legs were and tight. When I took her blood pressure, it was like, honestly, it was like 180 over 100. So we had to get that baby out quick. Because I was like, this lady's going to seize. And she was coming in, she was even having headaches. That means the perfusion is not good to the brain. So when it's getting to the head. So what we want is, with preeclampsia, we don't want it to go to eclampsia. What is eclampsia? Eclampsia is simply, you have a seizure, and that's what we're trying to avoid. We do not want to have a seizure. That's what we don't want to have. So if you come to someone's house, they call you, they're at home, and let's say you get there and people are running around like, hey, something's going on with her. We don't know what's going on with her. She has a splitting headache. She's taking Tylenol all day. It's not working. Baby's crying. You take her blood pressure and right away it's like 160 over 100. Like, don't waste time. Like, take her right away, because you don't want her to have a seizure. Okay, you don't want her to have a seizure. What are we gonna do? Definitely cycle the blood pressures. Also, I don't know if you all have like pads. I'm not really sure if you have pads for, like, just in case they have seizures. Do you all carry pads? Or even pillows? You got pillows for the side rails. So just have side rails up just in case. You don't want her to have a seizure and fall off of the stretcher. So pad it to the side. That's what would be best to do. Also, I guess you all can get orders for magnesium, because we want to prevent a seizure. So if you can start that, do that. You'll do a loading dose of that. Now, let's say you get her and she's actually pregnant, and she's having these symptoms. First, ask her right away, how many weeks are you? Okay, we want to know that. Also, ask her, do you feel the baby? Is the baby moving? And if she says, I'm not sure, I don't know, whatever. I don't know if you all carry Dopplers, but you can get a Doppler. If the baby's full term, Doppler here. If the baby's full term, you can find the baby, usually the baby's full term and head down. You can find the baby in the lower quadrants, either right or left, depending on where the back is. You can hear it down here. Okay, if the baby is head down. Baby's breech is going to be up here. So if she said the baby's moving, then you know that at least you have a live baby. You know that. Okay, so we're going to get that. So get the vital signs constantly, every 15 minutes. Make sure you put an IV in her. At least, you can put an 18 gauge. 20 gauge is okay too, but 18 gauge for that. What I would do, put in 2. One would be for the mag, and just in case they have to do anything with the baby and give medications on this side, or give medications to her, they can do that on the left side. So if you could put in 2, that would be great. Positioning. If she is pregnant, do not, and I repeat, do not lay her flat. So this is me, I'm pregnant. Don't lay her flat on the gurney. Do not do that. Why? If it's a full-term baby, the baby's weight will compress that vena cava down here, right down here, and it will compress it. What will happen is the mom will become hypotensive, and the baby will also start to, if the baby was on a monitor, the baby's heart rate will start to dip, and we call those lates. So what happens is that the mother herself is not getting perfused, as well as the baby's placenta is not being perfused as well. So that baby's not getting the oxygen, the nutrients, not getting anything that it needs. It's not even getting enough blood. So do not lay her flat. Preferably left side. Tilt her to her left side. Okay. Also, I know you're in the ambulance, but a lot of times too much noise or lights, if you can dim the lights a little bit, I don't know if you can do that. Dim the lights a little bit and tell them don't put on the siren. Just have the lights on. Because all of those things, all that stimuli can increase the blood pressure. All that stimuli. So we like to have it calm. I mean, of course, it's not calm, but to the best of your ability, have it like a little darker if you can. If you have eye shields, I don't know, you could put that on her just to calm the situation down. Mag, you can give 4. I saw that you can give 4-gram IV bolus, and then maintenance is 2 grams. So by the time you get to the hospital, the 2 grams should be starting there at the hospital. But you want to give them that bolus because magnesium is not for the blood pressure, it's for the seizures that we're trying to avoid. I think I saw you. Do you all give the EMT that came to visit, was giving me advice or whatever? He said you all give labetalol now? He said you all just started? Is that true?
Good question.
I think that's what he told me, but I wasn't really sure. He works for
Labetalol when it's not on shortage.
You said when it's not on shortage? Okay. So labetalol is also a good medication, and even if she's pregnant, it's okay for the baby. So if you notice the blood pressure is very, very high, then you can give labetalol and the magnesium. It works very well.
That would have to be done. Both of them would have to be done with consult.
Okay. And when this happens you have to call and communicate it. So you don't call and say, oh, her blood pressure is high, right? You have to be really specific. And then
the consult will be very specific. They would give the vitals exactly as they got them. And they'd probably give it at that point the series of them because it would have been repeated at least once.
Perfect. Okay, good. Yes, so we want to do all that. Now, what we look for when they're on MAG, I guess the trip won't be that long, but this thing called magnesium toxicity. And what happens is when someone actually is preeclamptic and is pretty, severe, they have things like the urine output is very low. Also, their reflexes, when you do, like, how you do a regular reflex and it's like a +2, like kind of like this, it's like really like karate chop, like that, karate kick, like really aggressive and really like hyper. So also the breathing, you want to make sure that they're breathing properly. So things that we check to see what their reflexes are like. So if it was +4 before 4 and now it's +1, and now she's breathing like under 12 a minute, or well, I guess you couldn't necessarily you can't assess the urine. You can't assess that.
Fortunately, we won't have anyone in an ambulance long enough to achieve magnesium toxicity.
Okay, good. Okay, good.
In the hospital, but not in the ambulance.
Okay.
I even think we carry enough that we could do it.
Okay. So don't worry about that. Delete from the record. Okay.
Fine.
Okay, so hypothetically speaking, let's say she has a seizure. You just do seizure protocol. Make sure her airway is open. If, like I told you, if she's in the stretcher, if she has, just prepared with, I guess, pillows, or if you have, they're like little pads that they have for seizures. I don't know if you all have that, but just make sure that she's in a safe area. So let's say if you're outside or at her house, just make sure she's, if the person's in a safe area.
We have a pretty good protocol for seizures, and
Good. Okay.
that sadly we're very experienced with that.
Oh, really?
And lots of people like to have seizures, whether it's an epileptic, alcoholic withdrawal, head injury, eclampsia.
Okay.
We have actually pretty good protocols to address that.
Okay, perfect. So that's what we're gonna do. Okay, so goals here, we're gonna identify if it's preeclampsia. If the blood pressure is high, just assume preeclampsia. If she's talking about she has symptoms such as the epigastric pain, the headaches, the spots, blurred vision, the swelling, she has all of the signs, just assume that it's preeclampsia. Make sure you communicate. And Dr. Sago said that, you all talk, I guess, consult, I guess, with the physician or whomever, PA or whomever you talk to in the ED. They can guide you through and then get the information they need. And also transport immediately. Don't wait, because we don't want them to become eclamptic and have a seizure. That's the goal, not to do that. Because the reason why, too, is because if she's pregnant, what happens is that the uterus becomes like a titanic contraction. It doesn't stop. So if she's seizing for 3 minutes, that uterus will contract for 3 minutes. And during contractions, what happens? The baby doesn't get the full amount of oxygen. So that's why contractions are usually like at the most 60 seconds, and then there's a little rest period in between. But if it's for 3 minutes, that means that baby's not getting enough oxygen for 3 minutes. And that's what we're trying to avoid. So that's why it's very important to try to get that magnesium on board as soon as possible. Okay. Questions on that? No questions? Okay. Okay, we'll go to the next.
Would you like to talk a little bit about OB trauma with domestic violence?
Okay.
Sadly, that's also see more times than anyone wants to deal with.
Okay. So can I talk about it in reference to placenta abruption?
Yeah, absolutely. In reference to the baby and the mother and what should be done in transport.
Okay, I'll talk about it in my placental abruption.
Okay, good.
Okay. 1 second. Okay, let's see. The last one. Okay. Oops, you can see this? Okay. Okay, we're going to talk about placental abruption, and I'm going to discuss the trauma. And you all can see, right?
Yes.
Yep.
Okay. So placental abruption occurs 0.6 to 1.2 percent of all pregnancies, is a medical emergency that needs intervention, and 10% of preterm births is caused by this abruption, and 10 to 20% perinatal death. So it's a very serious thing. Now, when placental abruption occurs, it's really not fixable. So placental abruption pretty much is this placenta is connected to my uterine wall, right here, this side, right to my uterine wall. So just imagine it being snatched off of my uterine, just like pulled away from my uterine wall. What are some causes of that? Cocaine use. So someone who's on cocaine, high blood pressure, preeclampsia, gestational hypertension, anybody who has any hypertension issues, trauma, as you spoke of. So a lot of times, actually, domestic abuse goes up while people are pregnant. So someone will say, oh, I fell down the steps. And this is the second time falling down the steps. Why are you falling down the steps? Like, this doesn't make sense. Like, so that should be a cue to you. Like, I just picked her up last week and she fell down the steps. And she fell down the steps again. Or, you might have a situation where you might see bruising on the belly. Okay, you see bruising on the belly. Sometimes it's just unknown what causes it. We just don't know what happens. What happens too is it happens most times in the third trimester, and after 20 weeks, premature separation sometimes occurs as well. So it's literally the placenta detaches from the uterus. Now, if it's just 10% of it, sometimes what happens is the body will actually clot off that area, and the baby will survive and it'll be fine. But if 50% of it is detached, is not going to be a good prognosis. Most likely, the baby only has minutes to get out of there because baby will pass away. Right. I had a friend that had an abruption. And she had twins. One of them actually died in utero, but the other one did not die. But when the baby came out, the baby actually was severely compromised and actually was full care all of his life until he passed away. And I think he passed away at the age of 18 or 19, but full total care. So he was not getting the perfusion. So the body clotted off, but it wasn't enough perfusion that the second baby got, and baby was severely compromised. Okay, now how do I know? So every bleed, because sometimes people like, oh my God, I'm bleeding, and you come there, it's like just a little spot, okay, of blood, or it's that blood that I was talking about, that bloody show, that mucousy blood. What we're concerned about, we want to see if it is like dark red blood, and this woman is not acting like labor pain, like she is screaming. So just imagine someone just ripping something out of you. She is screaming. It's painful, doubled over pain, as well as when you touch the abdomen, it's going to be hard, like your forehead, very hard. So those are signs that you should think, you know what, this might be an abruption. Okay, so we're going to ask, what question are we going to ask? What do we always ask first? Let me see if someone can answer it. Just someone yell it out. What do we ask her first? Or the family member? How pregnant are you? Yes. How many weeks are you? Yes. That's what we need to know. Because we need to know, are we saving 2 lives or 1? That's what we need to know. So if someone says they're 21 weeks, then we know we need to save that mommy's life. Now, of course, mommy is always number 1. The mother is always number 1. But if she says I'm 39 weeks, okay, we need to hurry up, because that baby, maybe potentially we can save that baby's life. maybe. So let's hurry up and get out of here. Now, also, we need to see if she has signs of any shock. Okay, so now when we say shock, we're talking about, like I was saying before, she's looking pale, she's diaphoretic, she's in and out of consciousness, she doesn't know where she is, no capillary refill, you know, all those type of things you might see. You know, she's very, very pale, like those type of things. So if you see that, and the vital signs are completely off, those are things of maternal shock. So how are we managing it? So if we get her, let's say we get her in, we get her inside of the ambulance. One thing we're not going to do not lay her flat. Remember, she's already compromised because she's bleeding out. But you can lay her down, because if she's bleeding out, let's say it's a massive, like massive amount of blood coming out. She's bleeding out. You can lay her down, but make sure you tilt her to her left. Just tilt her. Okay, so that baby is not compressing the vena cava. And then, of course, also she's bleeding because she has an abruption as well. So we don't want to, you know, compromise the baby even more. So if you can, ask her, is the baby moving? Or if you have a Doppler, get a Doppler and get the heart tones if you can. Vital signs, very, very, very important. Make sure you get the vital signs in the mom and cycle it. Okay, I would cycle it, like I said, every 5 minutes, just have it going on. Feel the belly. You're gonna feel that abdomen. Is it rock hard? Because the body, the uterus is gonna like stay in a contraction state. So it's gonna be really, really hard. So is it hard to touch? See the blood, is it dark? Assess all of those type of things. You know you're gonna ask about the age and fetal movement. And remember, IV, 18 gauge. How many we need? Two. Do two. One on both, one here, one here. Okay, and then when you're in that ambulance, make sure you give fluid. Make sure you give that fluid to help her volume of blood. If there's blood like chucks and you have, save it for them. Save it for the hospital. Save it for the nurses and the doctors, so that way they can quantify how much she has lost and notify the hospital that this is what you presume. I think that this is an abruption. She's doubled over in pain. She's screaming. The blood is very dark. Now, let's say you come in and you notice the blood is like red, like the type of red, like when you cut yourself and it's like bright red, and she's not in pain. Previa, placenta previa. Placenta previa is simply, the placenta is like this. The placenta is before the baby. That's all it is. So it's kind of like this. And it's on the cervix. So sometimes the person will have breakthrough bleeding, but they don't have any pain. There's no pain. It's not ripping off of anything. So it's bright red and painless. So that's how you will know the difference between previa and abruption. Abruption, painful, dark. Okay. So let the hospital know what you have seen, what has been occurring. And this person is going to 100% have a C-section. So we want to prepare her for that. Also, she might be frantic. So try to support her. Try to talk to her. You know, try to tell her, like the other scenarios where you're like, look, you know, we're doing everything we can. We're trying to get you to the hospital. Hold her hand, comfort her, because she's going to be in excruciating pain. Also, if the family members are there, tell them what's happening. Tell them what you think that might be happening and what you're going to be doing. You're taking her because you feel that she might be having a placental abruption. So let them know that this is what you think this might be happening, and go as soon as possible. Let's see here. Oops. Just didn't come out right. Let me go back. Okay, so any questions on that? I have a video that I want to show you all. And then after the video, I want you all to get together. We're going to have a breakout room. And let's see here. Let me stop this. Okay. You have any questions about this one before I get to the video? Because I have a little scenario, like a live case study.
Let's move forward.
Okay. Get this up. Hopefully you can hear it.
Scenario. You are dispatched to the home of Joan, a 38-year-old pregnant schoolteacher at 34 weeks gestation with a known anterior placenta. Her obstetric history is G4P2103. She is expecting a male infant and has a medical history of chronic hypertension, managed with nifedipine, which she typically takes with lunch. Today, she missed her scheduled dose.
Oh, I love my husband. It's been such a busy day. Oh, he drew a bath for me. Okay, let me just relax.
Oh my God!
I have to call 911.
911, what's your emergency?
Please help. I was preparing the bath for my wife, and after an hour, I don't know what happened. I came back and she was bleeding everywhere. Please send help.
Where's the EMT?
Somebody help, come on.
Do something.
Come on, somebody help.
Do something.
What's going on?
Oh my God, bleeding all over the place.
You need help? What's going on? What's wrong with it?
When did
You saved the baby, bro?
When did she start bleeding?
What's going on?
Listen. It doesn't seem like you're the one who's pregnant right now, so I'm gonna need you to calm down, okay?
My baby.
Let's get it. Just do something to help, please. Just
Are you
help.
pregnant?
Oh, yeah, pregnant.
How old are you?
Help. Come on, take it to the hospital. Take it to the ambulance. Hurry up.
You're not the one who's pregnant right now, okay?
Oh my God.
Can you stand with me and walk? Do you have any like pads on you?
Oh, my bleeding.
All right.
Where's the vein? I'm bleeding.
Just stuff that in there, okay? All right. Can you walk with me?
Okay. Is it gonna take it?
Come on, let's go.
Okay. Oh my God.
Okay, I'm gonna go get my children and bring them to the ambulance, okay? Okay, my two kids. My two kids.
That's
Bring
not
my two kids to the
That's
ambulance.
not gonna work, bro.
Come on, let's go.
That's not gonna work.
I'm sorry, my love. Can you save the child?
I can't do any of that.
My God, what's going on?
So
What did you bring in?
I know she's 35 years old. I know
Okay.
she's pregnant. I don't know how many weeks.
What do you mean? You don't know? She's pregnant. I mean, like, is she 20 weeks? Is she 39 weeks? I mean, it's obvious she's pregnant. I mean, really? That's all?
The
Okay.
husband was a basket
Okay.
case. The mom was a mess.
Okay, give me vital signs. What vital signs do you have?
I got blood pressure of 180 over 100.
What?
Yeah.
Is she hypertensive?
I don't really know. I don't know if she takes meds for it or if she has like a history of
Okay,
it.
what else?
The heart rate of 122.
Okay,
98% on room air.
okay.
Respiration is 24, I think.
Oh, wow. Okay, that's
And I got a 20 gauge in the right AC.
20 gauge?
Yeah.
Okay. When did she start bleeding?
I don't know. I also don't really know the cause of the bleeding. They couldn't tell me anything.
Okay, how much blood did she lose?
I know she showed through about 2 pads. Looked about bright red.
Okay, did you bring him in with you?
No. I threw him away at the house.
Wow. Okay. Okay, does she have any medical history?
I don't know. This is really a hospital problem now. I did my job. I brought her to the hospital.
Oh, wow. Who do you work for? Oh,
Baltimore
wow.
County.
Wow. Okay. Okay, do you have anything else for me? Nothing?
I got a run number for you and my unit number, but I don't have anything else.
Okay, so all you have is the vital signs, and then you did a 20. Did you give her fluid? How about that?
No.
Okay, thank you for nothing.
I did my job.
Did you all like our acting skills?
I'll just say I'm glad that's not real. I'll leave it at that.
Oscar material. Okay, so what I wanted to see if you can try to break out rooms. I'm not really sure. Can you get the breakout rooms?
Yes.
Okay, I have questions. Hold on. This is not up here anymore. Let me get the questions.
Did you want to share the questions here before I send everyone in the breakout rooms?
Yeah, I'm trying to get it up. It's on here. Hold on. Yeah. Hold on for a second.
I don't think there's any current questions in relationship to the last 10 minutes.
Okay.
But if you'd
Dr.
like-
Siegel, I think
So the questions are, can you see the questions?
no,
No.
but I just wanted to
Okay,
add
I
with
can-
Dr. Siegel, Jay Clements is asking for you to elaborate further on that question from Sean Sykes about how to
I
transport.
answered it. Yeah, I did answer that question for him.
Thank you.
Okay, I'll just mention the questions. Since we're short on time. Okay, what did the first responder fail to do or do incorrectly at the scene? What critical information was missed or omitted during handoff to the receiving nurse? And how could the EMT have improved communication and care during this emergency? Okay. Did you all get it? Let me see. I don't know. I guess I could put it in the chat, right? Put it in the chat. Let me see. So can you do it now?
Yes.
So you all gonna take about 5 minutes, just get together and then answer these questions and see how you would do it differently. And it's in the chat. I don't even know if it's working. I guess it's working. Join.
Is anyone having trouble moving to their rooms?
Anybody want to volunteer on some cues?
I think everyone's slowly moving back in.
Oh,
We gotta
okay,
give
okay,
them some
okay.
time to join.
Oh, okay, got it.
I know what you were talking about now before we started the conference today. That little
Oh, you saw it?
surprise.
You saw it?
I think it would be a video Easter egg is the term. I will say there is no prenatal room at the L&D department that looks like the one they were standing in.
No, and you notice that I didn't have, I was like, oh my God, I didn't have shoes on. We didn't have shoes on.
I was curious about the white socks
Yes.
because we went into this whole thing about issuing boots and hard steel tips shoes. So
No, because he was we were in the house. We were like, this is the best place to have it that looks kind of like hospital-ish. We're novice actors, so.
there was too much room in that room for it to be a hospital.
Is everybody back?
Yes.
Okay. So cues, can any brave soul answer the question of some cues that you saw that you're like, okay, you know what? This is most likely an abruption. Or even heard.
Dispatch history, arterial blood, frequent sudden pain after the water, hypertensive.
Yes. Okay. Anything else?
Initial question, did not ask how many weeks.
Yeah, they did not. Yeah, they surely did not ask any. What else? Anything else? They also she did. They did a blood pressure. It was high, right? Very high. So 180. It was 180 or what? I think 100 or something like that. Also, she had an anterior placenta. That can cause an abruption because she fell. Trauma. She had trauma, right? So the legs going up and down, that was trauma. She fell. Any other cues that you saw? Okay. What did he do wrong? Or could he have done better?
Could we just say what he did right? And
Okay.
that would be probably nothing. I mean, he got the patient to the hospital. That's basically what he got right.
He was in training, maybe. Okay.
No, there's a better standard than that.
What could he have done better? Somebody answer.
There is no real like empathy towards the patient, wasn't really communicating well with the spouse, didn't get any kind of patient information, no history, had her walking out to the ambulance, I'm
Yes.
assuming.
Yes,
Uh,
yes.
so yeah.
Anything else? Did you see that he told the husband to put tissue down there? Nah, I'm pretty sure you're not supposed to do that. Just random tissue. Yeah, that came out of his pocket. Yes. Anything else could have been done?
Oxygen, IVs, pre-alert the hospital, some
Thank you.
fluids,
Yes.
consult the hospital for magnesium for the hypertension.
Thank you. There's a whole lot that could have been done and stated to the, and then also the vital signs should have been done, remember, at least every 5 minutes. She's bleeding out. Okay, let me see. Follow-up question. I don't get that one. I don't understand. 2 transport units, what was that?
I think they were asking a question previously that they just wanted you to answer
Okay.
about a separate scenario.
Okay. Okay. So the alcohol was actually apple cider. So, he could have even asked those type of questions too. Like, are you, was she taking any drugs? Was she drinking? He didn't ask all those questions. So it was apple cider. That was apple cider.
He
Okay.
could have also called and radioed for help. He seemed a little out of his depth and maybe another unit.
Yes. Yes, could have. Now with the report, what could he have done?
That would not be considered a report at any hospital.
At all. And then also, if you notice, his attitude was like real nonchalant. Like, whatever, I did my job, whatever. I did my job. Yep, taking the pads. Yep, could have taken the pads, definitely. Had a list of all the vital signs that he had. If he did them, he could have done vital signs to have that. And and who said the preeclampsia? I didn't even think about that. That one I didn't even think about. Definitely. So started that protocol as well. So those are all some good, good things. I didn't even think about the preeclampsia. So those are really good things. Any questions or concerns? I know you all are tired. I'm tired too. I get it.
I have concerns for that EMT who was in the video, but other than that.
You said, what did you say?
I have concerns for the EMT in your video. He needs remedial training. But other than that, no. I think this is very informative. I thank you for coming tonight. It's a lot of information and a lot of knowledge in normally these are very emotional calls, especially on the parents, for the mother and father side. A lot of people in EMS get a little nervous with babies being born because it's not in the top 10 most common calls, even though it is in there. And especially the first time you have to deliver a baby in the field, it's very scary to the providers involved. But it happens. And the nice thing is babies have been delivering themselves for thousands of years.
Yes.
And we're just there to assist. And the other part of it is, at least for Baltimore County, that you're nowhere more than 30 minutes from any hospital.
That's true.
Although for OB patients, if possible, you want to take the patient to the hospital they are registered at. If it's a life-threatening emergency, you're going to take them to the closest appropriate facility. But if there's any amount of time, wherever they're registered, and they'll tell you where they're registered, that's where you want to take them because they're going to have all their records there from previous visits. Not that they can't be gotten by the other facilities, but it's more readily available at the facility they're registered in. It's very rare, everyone knows I work at Sinai, that we get an unregistered OB there, but it does happen, and then you're starting from scratch, but that's very rare at the 100 plus babies born there every month. You just don't see it.
Yeah.
Thank goodness.
Yes, yes. Because sometimes you don't know what you're going to get.
Nope.
Yes, yes. That's very true. So, well, thank you all for having me. I hope you learned something. If not, just at least one thing. I hope you learned one thing out of the presentation. So thank you all for having me.
I'm glad I can't get pregnant. That's what I've learned. I'm very glad I can't get pregnant. Oh my gosh. Thank you very much. If anyone has any questions about getting continuing ed through MIMS, you can type it in, stay on the line. We'll hang here to talk to you. I thank Nana for coming. We truly appreciate it. You definitely have a passion for teaching. It's obvious. And that's a good thing. That's a very good thing. So, but any questions in the chat for CME or in general, type away.
Can I get a CNE too? I'm joking. I'm joking.
Are you registered through MIMS?
What'd you say?
Are you registered with MIMS as an EMT or a paramedic?
Nope.
You have to have that ID number for it to go through, but otherwise, I'm happy to put it in.
Oh, well,
You're gonna look at me funny.
I said, let me just try.
You're in an education program right now at Salisbury. You're exempt from the continuing ed because your education program is
that's continuing education. Yes, that's true. Very true.
Yeah, until 2 years after you graduate, and then all of a sudden you find out how much did that cost?
Yes.
Let's see. I haven't. Terry, talk to Akiva. He handles that part.
Okay, so
that would be for the chat.
so it's probably not MIMS. It's probably just making its way to us through other means,
Yeah.
right?
Yeah, for company trainings, you'll talk to that would be Akiva for your company.
Okay, thank you. And thank you very much.
One earlier.
Thanks.